Welcome everyone to the 2022 Corman Impact Honors Program. I'm Sherry Carey, Director of Member Operations at the Schwartz Center for Compassionate Healthcare. We are thrilled that you have joined us to celebrate this year's honorees represented by a group of outstanding healthcare professionals. When we created this recognition program, we wanted to bring attention to the incredible work our Schwartz Center member community does every day to prioritize compassion in healthcare. The Corman Impact Honors celebrates Schwartz Center healthcare members who are making a transformational impact by creating programs or initiatives that promote compassionate collaborative care within their organization or system. This recognition program is underwritten by one of our most dedicated supporters, Steve Corman, as a tribute to his late wife, Betsy, and to reflect his belief that leading by example is the most effective way to inspire others. Steve, all of us at the Schwartz Center are grateful of your continued generosity, and we are incredibly lucky to have your support. With that, I am pleased to introduce Dr. Beth Lown. Beth is the Chief Medical Officer at the Schwartz Center for Compassionate Healthcare and will be our moderator this afternoon.
Thank you so much, Sherry. Good afternoon for some of us, I suppose. Good morning for others. Welcome. I'm so excited to be here with you and with these wonderful, wonderful awardees. I'm going to go ahead and introduce our honorees, and then we'll kick it off and get going. So first, I'd like to introduce TJ Patel, Esquire, a Certified Professional Health Risk Manager, who is the Associate Risk Management Counsel at Cedars-Sinai Medical Center in LA, and a member of a multidisciplinary team, the Human Trafficking Response Task Force, which she will tell you about. Frances Oliver is a clinical psychologist at Te Whatu Ora Health New Zealand, Hawke's Bay, and a leader in their relationship-centered practice initiative. Heather Mayer is a registered nurse at Oregon Health and Science University Infectious Diseases Division and a member of the Options DC team. And Lisa Cooter is a registered psychotherapist and program manager at Sunnybrook Health Sciences Center in Toronto for the Family Navigation Project. So I am just really excited that everyone is here to listen to what you all are doing. I want to encourage everyone to put some questions, anything you would like to know, into the Q&A so we can address them at the end of the webinar. So feel free to write those in at any time. But I'm going to go around and just ask each one of you to just briefly describe what your program is all about, who it's for, why it's needed. And I'm just going to circle around what I can see, starting with you, TJ.
Hi, Beth. Thank you so much for including us. So at Cedars-Sinai, we formed a multidisciplinary response task force regarding human trafficking. And I know that's a lot of words, but essentially it's a way for us to educate our clinicians about what to look for in our patients and to identify victims of trafficking. And so that's been a training that we've been evolving for about 6 years. We're very proud to say we've educated over 2,500 clinicians. And really the important thing to think about and remember and why we're doing it is because, you know, if you think of human trafficking, it's reusing the commodity, right? It's the new bad thing to trade because it can be reused multiple times, unlike a drug or a weapon. And they're not going to see any care or any outside people until they're not being able to work or they're not being able to perform. And so it's really critical in the healthcare setting for us to recognize them when they do come in through our doors. And so that's why this training is happening. And we really want to spread the word and provide education and training for, you know, anybody who's interested in it. So thank you for listening.
Yeah, thanks, TJ. And I remember you telling us how shocked you were when you actually heard the statistics about how frequent it is and how so many people who are, you know, then recognized as victims of this had some interaction with the healthcare system, right?
Yes, there was about 80 to 90% back in the study in 2017. And so by now, I think, you know, we're hopefully more educated, but we missed about 80 to 90% of them coming in through the ED. And that's a staggering statistic to us. And so that's why we ended up starting this.
Yeah, so eager to hear more about actually what you did a little later on. Frances, you're up.
Kia ora. Good afternoon, everybody. Good morning from us here in New Zealand. Our program that we're so thankful to be included for is called Relationship-Centered Practice. And in effect, it's an education program that affords all health workers, no matter their grade or profession, the opportunity to learn the skills that we know that we need to build compassionate, caring and empowering relationships at work. The key to relationship-centered practice is that we did co-design it with our local iwi. A local iwi is the word that we use for our local Māori tribe. Māori are the tangata whenua, or the indigenous people of New Zealand. And the reason that that matters is that building relationships for Māori looks a little bit different to how we would traditionally think about relationships from the Western worldview. For us here in New Zealand, Māori are highly overrepresented in adverse health outcomes, and we know that we don't serve them well as healthcare organisations. So it's really important that we think about how we do things differently. So the programme is also co-delivered by one of our cultural leaders here in our healthcare organisation, and provides healthcare workers that safe space to think about what they can be doing differently in their day-to-day work.
Thanks, Frances. Can you just say one word about the worldview of the Maori? It's just different from ours, you know.
I think one of the key points of differences is relationships. Although relationships matter to everybody, and particularly those of us who choose life working in healthcare, for Māori, relationships are essential to working together in a collaborative way. And from a Māori worldview, what I have learned, not being Māori, is that they are built on a connectivity, connectedness to land, connectedness to family and people, and how they locate themselves within that connectedness. And so for healthcare workers, it's learning about how you can build relationships in that way, while still maintaining your professional boundaries. And the word that they use for that relationship building is whanaungatanga.
And that literally means relationship building, does it?
It's slightly complicated. O means myself, whānau means family, whanaunga means the wider connectedness of family, and whanaungatanga means the process of putting oneself within that connected network of whānau or family.
It's so interesting and it's so fascinating and it's so un-Western and so holistic. There's just such a beauty to that sensibility and those perceptions. Thank you for sharing those. Yeah. So Heather, how about you? Can you share a little bit about your program?
Of course, I would love to. So Options DC is all about taking the patient's priorities and goals and using that information to inform care. So Options DC stands for OPAT and Impact Next Steps Discharge Conference. OPAT is our outpatient parenteral antimicrobial team within the infectious diseases division. And we manage patients in the community on IV antibiotics. And then Impact is our inpatient addiction medicine team. So these two teams came together to create Options DC. And it's a meeting for patients with substance use disorder who require long-term IV antibiotics to treat their infection. And then the patient's care team comes together to discuss this template of questions that we have that help us determine the most optimal setting for treatment of the infection based on the patient's goals and their priorities. So prior to the options, patients had really limited opportunities for where they could receive treatment for their infections, and generally they'd have to stay in the hospital for the duration of treatment, which could be up to 8 weeks. And as we know, staying in the hospital is really challenging for 2 months, and it's not really manageable for many of our patients. So this led to a lot of self-directed discharges, which meant either no treatment or suboptimal treatment for their infection. And so with the Options DC, we've been able to challenge the culture of paternalism in our institution by utilizing harm reduction principles and honoring patients' goals and preferences in order to provide patient-centered care.
Yeah, it's amazing. I think, one thing that really struck me when I first heard about it was how you have been able to really unite substance use disorder teams with the ID teams, because that often, it seems so clear and obvious a need, but it doesn't always happen, and I think that lack of integration, the siloing of those two teams really is how patients fall through the cracks. And I think that's one thing that really, really resonated with me about your program. Thanks, Heather. Yeah.
Of course.
And Lisa.
Oh, thank you so much, Beth. It's so great to be here with such esteemed company. So the Family Navigation Project, we provide system navigation for the mental health and addiction system. And we work with youth aged 13 to 26 and their families to understand and find access into and through the system. And one of the things that really prompted the development of the Family Navigation Project was the fact that the mental health and addiction system can be really complicated and challenging, particularly for someone who's never accessed the services. Where do we start? Who do we go to? How do we know we're finding the right place? But also for youth and families who might already be in the system, it's not uncommon to hear a story that they get to a service, they're on a waiting list, and then they get picked up and they've aged out of that service, or it's the wrong service. And so really what we do, we've got a team of clinically trained navigators, and we help those teen, youth, the young adults and or their families to navigate that system more easily. So we help with providing some psychoeducation. We help them to figure out how to get into those services. We build partnerships with other service providers to help make those, to facilitate smoother transitions into the systems. And we really believe in trying to find the services that are best matched for the youth and their families. So we try to do a personalized approach. It's not a cookie cutter approach by any means, and we work collectively as a team. We also try to do this through a low barrier approach. So there's no referral required, there's no diagnosis required, there's no cost to our service. We engage with families by phone and email so that they can connect with us at the time that's right for them. And we stay involved with them along their journey. So it's not a one-time thing. It could be, as long as we get them connected to a service, maybe we're getting them connected to multiple services. And so we might work with the youth, we might work with the parent, and we might work with the whole family to ensure that they're getting what they need so that they can see the most positive outcomes.
So you mentioned they're not charged for these services. Can you say a little bit more about that, please, Lisa?
Well, sure. So we are, although we're part of Sunnybrook Health Sciences Centre, which is a fairly large hospital in Toronto, our program is 100% philanthropically funded. And something that we felt was really important was that everybody could have access to the supports to help them get into the system. And we will seek out any type of services that they need. So we will access the public service sector, or if they need something else, we'll connect them to that service. So it really is about ensuring that everyone, regardless of where they come from, that they have access to really good quality support as they try to navigate and understand that system.
Thank you so much. I don't know, for anyone who's ever had to access services for their loved ones, you can probably know what a disaster it is. You just feel so alone out there, just no way to understand who's going to really help, and what the most effective ways to go about that might be. So it's an important service. All of these programs are just absolutely so essential and so necessary. So I wanted to ask each of you to share a little bit of a story, if you have one, a story or memory about a patient or family, or even a colleague, who was touched by your program in some way, and why that person stays with you. So again, let's, TJ, I'm sorry, I'm just going to keep going around in circles. I'll start with you.
That's okay. So it kind of goes back to, the training that we have. It's been evolving for this many years. And one of the very first patients we had was a minor from the trauma department. And we hadn't expected we don't know what we were expecting when we started this. And she came in because she was either pushed out of a moving vehicle or jumped to get away from a trafficker who had committed a crime. And, I guess she had seen him do that. And so we had, just by chance, educated our security team the week before, I believe, about trafficking and, just the signs and symptoms, what the language that they use, the behavior that they're going to display. And a security guard kind of felt something fishy about women who came in through the security guard, through the ED department, asking for her sister. And something in the way she asked, something in the way, the wording that she used, the security guard actually notified the response team. And that's kind of what we do, is we educate, but then we also serve as kind of that group of extra knowledgeable people about what to do. We've vetted all the local resources. So we know once we do have a victim that's identified, if they want help, where to send them. And we have that, relationship with those people. And so in this story, that patient had been trafficked. Another fellow victim had come in as a spy, essentially, for the trafficker, wanted to find out the room. And because of that security guard, we were able to, put her under a Jane Doe and move her a different floor and kind of get her, extra security as well on that floor for the safety of our employees as well. And so it taught us a lot of different lessons that we've adopted into our training. And that one always sticks out to me. And if I have another moment, I wanted to say that one of the cool things about doing this training is you're training a bunch of different people. And in every scenario, how we've built the group is because somebody's heard the training, had a passion for it, came and helped us, and added to our multidisciplinary team. And so I just wanted to mention that was one of the key things that we learned. And as we grew, it's just been kind of that organic growth that is wonderful to be here, to be appreciated. It's just great. So thank you again for bringing us.
Thank you for doing the work. So it's partly education, it's partly knowing where the services are. And you also mentioned actually helping people have difficult conversations with the victims who may not feel that comfortable. So almost like coaching or something like that?
Yeah, we have, a group of social workers that have been with us from the very beginning and helped us work on our training, but also our trauma-informed care approach with the victims. And so once we've identified them, that's that first step. And now what do we do? How do we talk to them? What's the approach and the demeanor that we take when we talk to them? And, especially if they're an adult, this may be that first time where they say no and it's respected. So we have to respect that if they don't want that help at that moment, and meet them where they're at. And so these are all the things that our social work team and our specially trained human trafficking response social workers, and we have them on the ED floor, a critical care floor, I believe, and a couple different other levels. And they just kind of come in and support the team on the floor.
Yeah, so helpful. My goodness. All right, thanks, TJ. Frances, do you want to share a story?
Sure. And thank you, TJ. It's so lovely seeing the stories bring these programs alive.
Yeah.
One of the stories that always sticks in my mind was a senior pharmacist who came along to our training. She was a hospital pharmacist. She wasn't a New Zealander. A lot of people come to work in New Zealand for a period of time. And the week after our training, she was up on the wards doing her medication reconciliations. And she walked into a bed space, and there was an older lady sitting in the bed space in a wheelchair. And the lady literally had her back to the pharmacist. She was turned around, and the pharmacist said, "Hello, I'm so-and-so." And the lady didn't spin around. She just remained in her wheelchair with her back turned to the pharmacist. And the pharmacist said she stopped and she thought back to the training, and she thought, what can I do differently here? What can I do differently to engage this person? So as we were talking about earlier, one of the key things in relationship-centered is practice is learning how to connect with someone and possibly even bring a little bit of yourself into that relationship whilst maintaining professional boundaries. And so she had a look at this lady's chart, and she noticed that one of these ladies' names had a family connection for her. So she said, "Oh, I noticed that this is your name. It's a beautiful name. I have a family member with that name." And she said as soon as she used that sentence, the lady spun around in her wheelchair. Up until that point, it was as if she hadn't been listening. And she said, oh, you have a family member with that name. How did she come to have that, be given that name? And they started this conversation about a name. And sure enough, a few minutes later, they were able to move on to the business, move on to the medication reconciliation. And it's just one of those key aspects of relationship-centered practice that if we do not take the time to connect with our patients and families, we're never going to help them move forward in their healthcare journey. It's a story that stays with us every time.
Yeah, I love it. Thank you so much. Yeah, I hope we don't ever lose that desire to sort of know who the patient or the family is, who they are as people in their own context, in their environment.
Absolutely. It's what's brought us here.
Yeah, absolutely. True. By the way, I want to encourage you guys to ask questions of each other too. So this doesn't have to be like, me in the middle. Heather, would you like to share a story?
Yeah, I'll just stay with the context of knowing the patient, who they are and what's important to them. So, and I'm also just going to keep it light. So we had this patient who was hospitalized for a couple of weeks, and her recommendations for treatment came out, and it was that she needed an additional 4 weeks of treatment. She had a sick dog at home. And if you know anything about Portland, Oregon, everybody loves their animals here. So her priority really was that she wanted to go home. She did not want to stay in the hospital any longer. She had a long history of IV heroin use. So all the teams were really hesitant about her being in the community. So we had our options meeting and sort of talked about her protective and risk factors. And we went through all the potential treatment options. And she was really well connected in the community. And we understood very well that her priority was to be home and caring for her sick dog. And she did not want to stay in the hospital anymore. So we found a supervised setting for her to receive her daily antibiotics, which meant she could be home with her dog. And then also we could be able to manage treatment, which is really, what we were hoping for. She was so excited to be home. Once she got there, there were definitely a few bumps in the road. Her priority, as she had mentioned very clearly, was that caring for her dog was number one. So she missed a couple of her appointments, but ended up getting through her treatment. And I think that particular story always reminds me that our priorities and our goals are not our patients. Then we really need to make sure that we put that as the focus.
Yeah, for sure. We often, I feel, make recommendations without really knowing what does this person want to do? What is this person capable of, and who's at home to support them, and what are their top priorities in life, just as you said, and so for some people it's going to be the dog, and for others it's going to be, who knows, children and all kinds of different things. But anything that can optimize this, because the failure rate of completion of antibiotics for serious infections and patients who have substance use disorders and the like are really quite astounding. Do you treat, you have homeless patients also in that group?
Yeah, absolutely.
How are those folks managed?
We are really fortunate to have a lot of resources here in Portland, and we have some really great organizations. There's a recuperative care program through Central City Concern, and they will provide shelter for our patients, and they have nurses there on site and a pharmacist to kind of help staff and just keep an eye on them. They're free to come and go as they please, but that's one of the resources we can use for some of our patients who have a housing instability. And then we have this amazing group of addiction medicine social workers that are so good at helping us find creative solutions for our patients who have housing instability.
It's great to have such a strong team. Thanks, Heather. It's wonderful. Lisa, how about you?
Oh gosh, there's always so many stories to share, isn't there, about, things that stick with you. I think the story that sticks with me the most is it's one of my navigators who had worked with a family. And I think it's an example of how sometimes we have to step back and help a family figure out how to move forward at a slower pace. And so this particular family, it was the caregivers that reached out for an 18-year-old youth who had some significant mental health issues. There hadn't really been a diagnosis because from the parents' perspective, the youth wasn't really interested in accessing services, but they were noticing a lot of increased substance use, alcohol use, a lot of, sort of hiding those kinds of things. And so when the family connected with the navigator, they just wanted treatment for the youth. But the navigator figured out that the family probably the parents really needed some support to help them figure out a different way of engaging with their youth. And so one of the things that they did is they worked with the caregivers to get them connected to some parent supports where they could learn different language about how to engage with their youth in a more less, this is what you're going to do. This is how you're going to do it. You live in our house. We're going to do this. Because what was happening is the youth was, pushing back, becoming really defensive, not really interested in conversations. And the other thing that the navigator did was the navigator engaged in what we call compassionate persistence, which I really think is an indication of, okay, I'd really love to talk to your youth. Do you think your youth would talk to me? And maybe if you say to that youth, if you connect with this person, they're going to help you figure out what's right for you. So the navigator also gave the family some language to allow her to have a conversation with the youth. And it was really interesting because the youth had a completely different perspective of what was going on. And so the navigator was able to work with both the youth and the caregiver, but on slightly different directions. So that with the youth, she actually got her connected to a youth outreach program that the youth outreach worker was able to engage with the youth from a different lens. So instead of a treatment, you need help, let's get you connected to a service that, maybe you can connect with other youth. Now, this worker also had mental health knowledge, so was able to softly start to engage in some dialogue. At the same time, parents were now engaging with a parent coach who was teaching them some language. And although this process wasn't quick, I'm going to be honest, it probably took about a year for everyone to kind of get on the same pages. Eventually, we were able to get the youth to a place where they were willing to get connected to a psychiatrist that the youth outreach worker had recommended, who did a lot of work at a youth hub. And so doing that, they got connected to a diagnosis. They started getting the support that they needed. The family eventually was able to engage in some family therapy through a program in Toronto. We've got some great programs that are publicly funded that involve the entire family, and so that they can help the family and the youth and bridge them together. And I think just for me, it reminded me that, we get a parent, we get someone coming in and they're looking for something, but sometimes we have to help them slow down the process and get to a place where they're on the same page, because not everybody looks at their journey in the same way. And I think that's something we like to do is to be personalized, so that the youth felt supported, the parents felt supported, and ultimately, eventually, they were all able to get supported together. And I think the nice part is we actually received some feedback from the youth about, it was the first time someone felt that she was being heard. And I think that was really important for her in her journey, to be able to think that someone has my interest at heart. They're not just trying to fix me, and they're not trying to tell me what to do, but they really care about me. And then the parents also felt the same way. It's a lot of work when you're trying to look for services and to support a loved one. And sometimes we have to help them slow their journey down to get their youth to a place that they're on the same page.
Yeah. Actually, it can feel like a full-time job sometimes for a family,
Yeah, absolutely, right? And so our dialogues can be really different, with each member of a family, because they all look at their journey through their own personal lens.
Yeah. Well, and of course, the family, of course, wants the loved one to just change immediately. I mean, they're suffering alongside with their child.
Yeah.
So they're way ahead of their kids' readiness to change, on that change cycle for the most part, very often. Do you bring the parents together in peer groups? I can't remember, Lisa.
So we don't do peer groups ourselves, but
Yeah.
what we do is we will connect them to peer groups.
Right.
And that's a big part of, the work that we do in the system. Now, we do have a parent support person on our team. It's a PAL, parent advocate with lived experience. who we will connect to caregivers, and that our PAL can also work with the caregivers around, like, this has been my experience in the system, and this is why I found this group really helpful. Or, you know, you could really benefit by engaging with other parents who understand the journey that you've been going on, to share language and strategies, and also to share hope that, you know, there is hope beyond the next step. You know, even though we're worried about our kids, they actually can see some really positive outcomes.
Important, so important.
TJ, I saw you had your hand up.
Did you?
Yeah,
Go ahead, go
I
for
was
it, TJ.
Thanks, Lisa. I was going to ask, you know, what struck me, and a lot of what you said struck me, but one of the things that was a lesson we had to learn too is giving language to our clinicians, but also to the victims. Is, you know, saying, are you a victim of human trafficking doesn't get you anywhere.
Yeah.
So, you know, that really was, I thought, an important piece that you know, also realized. And it seems like a lot of us, building rapport also means giving language to the person who needs to build the rapport in the right way. So
yeah, absolutely. And, you know, TJ, it's also language around, how do I communicate with the system, right? Because, you know, you get someone in distress, and you know, they may not be feeling that they're being heard, but if we can give them some language on how to connect with that service provider, how to make sure that they can share their concerns in a way that they're going to get a more positive response. Yeah, and that's a big part of the work we do as well.
awesome.
Yeah, I think we all share in that journey, right?
This came up in our discussion before too, Francis, with your program and your community there, how important language, of course, cultural understanding, but you know, understanding of what words mean to people is just really key. It helps you navigate the you know, the work. I don't know if you want to say any more about that. I think it's a really important point.
Absolutely, and for us, allowing our health workers to become confident in using basic te reo terms, which is our Māori language. It has been a huge journey for us here in New Zealand, which is growing momentum. I also really liked the term compassionate persistence.
Yeah.
And I thought that the other neat thing about coming to these forums is we learn new terms as well, which help really put meaning to the work that we're doing.
Yeah, it's fantastic. Yeah, I have to write that down. Compassionate persistence. I think it's really great. So let me pose another question here. In terms of sort of how have you demonstrated the success of your program? I'm going to ask Heather, you to talk about that a little bit. You know, measuring outcomes of these kinds of programs can be very, very, very hard. But do you want to just share a little bit about your thoughts?
Yeah, I would love to. So I think for us, the number one measure of success for Options DC is that it was a pilot program that is now standard of care. Anyone who is caring for a patient with substance use disorder that also needs IV antibiotics can request it. So case managers, social workers, providers, I think everyone is aware that it's available. And so you can feel comfortable saying like, hey, I definitely think this is what's needed here. And that's really nice. The other thing is that we've heard from a lot of providers that it's really nice to be able to have a group discussion about these really complex patient scenarios, right? You don't feel like you're the only one that has to make the decision. And I think for everyone that just feels just more safe, right? Like you have all the information, because I think it was Lisa who mentioned the PALs. We have something very similar, peer mentor, someone who's had lived experience, who always provides the perspective of the patient through that lens, which is so important. And I think during those Options DC meetings, information comes out that maybe all the teams didn't have, or maybe somebody wasn't aware of that one little piece of information that really makes a significant difference in the discharge planning.
Yeah.
Yeah. I think there was one more thing. Outpatient hospital time, right? So prior to Options, most of these patients would either have to stay in the hospital or they would have a self-directed discharge with suboptimal or no treatment. Now that we're able to meet the patient where they're at. Maybe IV antibiotics isn't a treatment that they can manage, but they can manage orals. So they go out on orals and they're getting some kind of treatment. It might not be the most optimal, but we're able to meet those patients where they're at and provide them with a treatment regimen that is also taking into consideration their goals and their priorities.
So I know you're going to eventually you'll be publishing all of this, so we're going to all have to receive, the copies of your paper. But this is, this is really important, and obviously it's going to reduce readmissions, and it's going to prove its return on investment, so to speak, to the hospital leadership. So they must see that if it's been made a standard of care,
Yeah, I would hope that they're seeing it. If not, I mean, you can feel the shift in culture anyways. You can feel just providers who were maybe a little more staunch about what they thought were the appropriate treatment options for patients with disorder are now the ones advocating for the options DC, or the ones that are saying, like, have we really thought about the patient's goals during the meeting, which, to us, that really it's huge.
Yeah, that's a huge culture shift.
Yeah.
It's really, that kind of flexibility is amazing.
And it's so nice to be here with this panel and see that that is happening everywhere. It's nice to know.
Yeah, it's really, it's very heartening. And Lisa?
About success, is that what you?
Yeah, just curious.
Okay. It's interesting. I think something we've been having lots of conversations about this, and I think we've realized is we're not defining success. It's our clients who are defining success for us.
Right.
And I think that's something that I'm hearing here, right? And for us, it's a fundamental aspect to our work is the involvement of families and youth in all of the work that we're doing. Ensuring that they are being partnered, that they're giving us feedback on what's working and what's not working. We also do embed our program evaluation into our service, so it's a fundamental part of that. And we're also really lucky to have a robust research and evaluation team that is actually integrated into our FNP team. And so we engage the entire team in dialogues about success, outcomes. We believe in a transparent approach. We are really fortunate that we have a really active parent advocate on our team. We have a youth advocate now on our team. We have an active advisory council, both for our youth and for our caregivers. And so they're all part of ensuring that our program continues to deliver really good quality service, and so that the families are the ones that are benefiting from the work that we're doing. So I think that's how we really do define success, and that it's about the families and the clients and ensuring that it's their voice that we're listening to, and it's their voice that's going to continue to guide us in our evolution. Where do we need to change? What do we need to continue to do? As the system gets more and more complicated, we need to get more and more creative, I think, to figure it out. And it's only by involving our clients in that journey that we can really be successful with what we do.
Now, it's so interesting because it puts sort of this into the center is the relationship.
Yeah.
Knowing patients and their family, family members as real people, whole people in a context, in a lived experience, rather than, these outcomes that may ultimately come to pass. But it's so important that somehow we have to figure out how to value and measure our own compassionate values and not give them short shrift in favor of what's going to save money. And, I understand that's important, and it's not an either or, but it's showing the value of relationships that shifts the culture, which is what's so interesting, I think, about what's happening in each of your programs, that somehow they're causing a mind shift. They're causing people to think differently and to prioritize how they relate to people, which is basically, the foundational principle of compassion.
Yeah,
So,
and it's Beth, as I was listening to all of us, one thing that also struck me is in those relationships that we're building with clients, we're also taking those relationships and that knowledge to the system, and we're engaging each one. I heard, they're educating the system around us to do a better job, educating around trafficking. So it's not just one specific group, it's a broad group. Heather, you talk about, making sure that service providers can look at better outcomes, and Francis, the same, right? It's involving the system in helping to make a better outcome for a community that really deserves it, right? And so we take those relationships not just with the clients, but we take it to the system. And it is about continuing to challenge ourselves to do a better job.
Yeah, I love that.
Yeah.
Thank you, Lisa. Absolutely. Please, folks who are listening, put some questions into the Q&A. Anything you'd like our panelists to speak to, let us know. I would just want to think a little bit more about, or hear from actually each of you, is if somebody wants to start a program like yours, what should they be thinking about? What are some of the very first steps? So TJ, you want to start us off on that? It's hard work and it takes time, but can you comment?
Happy to. So a bunch of different things I was thinking about, but I think the important thing for us was finding a really good partner to start off with training. And what I mean by partner is somebody in leadership, and it doesn't have to be somebody who's, all the way up in the C-suite, just somebody who has a knowledge of the system, who can kind of get you into the door, because if you want to train, you got to have an audience. So in my case, we needed somebody to help us get into that door. And we had a nursing leader who was on the step down unit, who was just an amazing supporter of us, and would make sure that all of her nurses were trained. And as soon as her nurses were trained, they were talking about it to their friends and their colleagues. And then they wanted it. They were like, hey, I heard this really interesting thing, and I think we missed a patient the other day that could have been a victim. And at every presentation, we would get that, I think one of our patients that we had last week. And it was humbling, but also satisfying in a weird way, even though the presentation is kind of sad. It's good for us to be trained in it. And so we were seeing the value. And I think the biggest thing for us was getting somebody to get you into the door, and then customizing, because our audience is so different. Like the dentists are going to see different things than the front desk and the security. So if you're doing a training, especially in healthcare, they have such limited time, got to have it customized. So that was kind of the two things that are takeaways from the very beginning.
Yeah, so important. Thank you.
Yeah.
Also, you have, I know that you said one of the very powerful things in your program is having someone who had actually been trafficked or had a story or a victim statement as part of your presentations.
Yeah, that unfortunately came later on, but we had an audience member who was administrative staff in a social work team. And she came up to us afterwards, after the training, and said she wanted to talk to us, and told us her story about her daughter who was trafficked.
Yeah.
And it was such a powerful story. Her daughter showed none of the red flags that we talked about in the presentation. And so we asked her if she would like to be part of our presentation, and she took a little while to think about it and kind of make some decisions. And she's now part of our presentation each and every. She joins us. She doesn't work for Cedars, but she still joins us. And she's going into social work now. So really powerful. It gives me chills still to think about it.
Yeah, that's amazing. And the courage, to talk about that, given the stigma and all of the reluctance.
Yeah, she's such a powerful lady. She's such a powerful lady and speaks so well. And yeah, it's very powerful. It definitely is, it gets people talking and starts conversation for sure.
Yeah, amazing. Francis, what about you? What do people need to know to sort of get this work going? What are your tips for getting started?
Well, I definitely echo TJ's tips there around having that leadership commitment. Our whole executive leadership team here at our organization have completed our training. And my partners in training, Anne McLeod and Laurie Tinahu, have just kept that persistence going and engaging leadership and understanding what the program about and why it matters, why it's important. And I think just as well, to build on the theme that's coming through about the importance of co-design and the importance of thinking about who are the community that you are engaging with, who are the community that you are trying to build something with, and making sure that from the outset they are holding you accountable for what you are building in that co-design and co-delivery. And I think another lesson for me in terms of thinking about working with a community which you may not be a part of is being willing to be put outside of your comfort zone, and being willing to engage in that reflective piece about who are you, and where do you sit in relation to this community, and being really willing to open your eyes to completely new and different ways of working.
These are so wonderful lessons. I love these. I'm writing everything down, taking notes. Okay, Heather, what about you?
Well, I'm just going to continue with TJ and Francis's theme of training and education. I feel like if you're really interested in a specific population, educating yourself about them. I know that if you are in Oregon or abroad as well, there's Oregon Echo Network, which provides all these amazing trainings like substance use in the hospital and just a bevy of information so that you yourself can sort of explore those topics. And then I think finding the like-minded individuals in your organization and coming together, because individually it can be really challenging to try to uphold that by yourself and keep that motivation, especially, you know, we're all really busy with our jobs, but when you have a group of people that you're working with and you're all working toward one goal, seeing somebody over here doing their thing, you're like, that's so inspirational. I'm ready. And I think that's part of what's happening in our hospital, is that it's really hard not to be inspired by this whole group of people that are, you know, across several disciplines who all have the same goals in mind. And we're all just working toward understanding, you know, we have some that are the experts, our addiction medicine team, they are the ones who are providing the knowledge to us and helping us stay on top of like what we should be knowing, but then also ourselves realizing that, you know, we can take steps ourselves to become more educated and understand these populations, and then advocate for them fiercely whenever we have the opportunity.
Absolutely. So great. Lisa, what are your thoughts?
Well, I agree with every single thing that has been said. And, you know, I think for us, you know, service navigation, one of the things that I think is also about building relationships with service providers in the area that you are working in. And so, and what I mean by that is it's, you know, let's say I'm working with, you know, a pretty diverse population. Toronto's got a very diverse landscape, and maybe the family we're working with is they're immigrants to Canada, and maybe the language in which they engage with isn't they don't have words, they don't talk about mental health, but they're still struggling. And so partnering with local service providers that understand that culture, so that we can learn the language that is needed to be able to do that work well. And so knowing your local landscape, I think, is really important. I think we've already said this, but really involving the voice of lived experience. Like, what is it that they need? What are the gaps that are happening in the service, in the system, that aren't being met, that navigation can really help fill? You know, how do we, you know, do we need to expand our population? Do we need to, you know, is it more addictions in this community? Is it more mental health? Is it related to a certain age group? Is it related to transitional areas? And then really working collaboratively. I think that that's a big part. It's relationship and collaborative based care, I think, is what we're all talking about. And so I think that, you know, all of those key pieces are really going to be important to ensure that you get systems working together, maybe even defining a common language. You know, I think about service navigation, and we were lucky to be part of developing the health navigation conference. And we've just started having dialogues about a community of practice so that we all understand the language from the same, so that we understand what we're talking about from the same lens, right? So service navigation could look very different in your community in Oregon, but in a rural community, it could be very different, but just as effective, right? And so knowing those landscapes and really working collectively to take advantage of all of the knowledge that's out there, because there's a vast amount of knowledge. And that's what makes the system so challenging, is there's actually so much knowledge. No one knows where to start, and get kind of the champions out there working together to kind of get it off the ground. And then partnering, you know, I think something that I probably think all of us do is, if anyone has a question, reach out to any one of us. We would be happy to share our journey and our approach and our successes and what are our lessons learned, right? So that we can make sure that we help other people be successful in their own communities.
Thank you so much. And we will be sharing your contact info at the end of this webinar, so folks stay tuned. So I want to make sure that we actually respond to any questions that anyone in the audience has. There is a question for you, Heather. What members of the team at OHSU were involved in the development of the Options DC model, and who leads or moderates the discussions during the meetings with individual patients?
So the development was created by providers in both the addiction medicine team as well as infectious diseases, the OPAT group, which is the outpatient parenteral antimicrobial therapy team. So they developed this template. And then what was the second question? I'm sorry. Who
leads the discussions, the meetings?
So that would be us, the infectious disease nurses. We coordinate either with, there's an administrator in addiction medicine who send out an Outlook invite. And so we coordinate that, as well as just making sure that we're going through the template and leading the discussion so that we can make sure all of the questions have been answered and that everybody gets a voice.
That's terrific.
Mm-hmm.
Do any of you guys panelists have questions for each other? Feel free. You can speak up if you do, and if not, that's totally fine. I'm going to just, Heather, did you want to say something?
No, I was just going to tell TJ I'll be in touch. I just think that it's such a great training, and that every facility, especially in healthcare, should, you know, be aware of what signs to look for.
Yeah,
please reach out. We will train for free anywhere that will take us. Love it.
Great. Heather, are you planning to share your template for the call?
Oh, I don't know. I possibly could. If somebody's interested, my email address will be up at the last slide, and I'd be happy to provide the information.
I think it'd be great for people who are interested in having these kinds of conversations. If it's possible, that's great. Anything you want to share, let us know. We can post it, you know, in right near our where the recording of this webinar is going to be on our website. So, you know, so far, here's what I've heard. There are a lot of themes that I've heard. One is, of course, the need to get leaders on board and engaged with what you're doing. Of course, that's the first step in any kind of change you want to make. But I think one of the nifty things is trying to actually have them take the training or the education, or to somehow be exposed to people who are involved in it, either as recipients or, you know, on the provider side. That's just such an important, this whole storytelling thing is, it's the key. It's the key. People need to hear about real life experiences that of the people that they're serving, whether that be on the provider side or on the patient side or families. So that's one thing that I'm really taking home. I think this whole notion of really the co-design notion, the notion of putting patients, families, communities, cultural beliefs at the very center of everything we do, trying our best to understand them and how to use that information to really modulate and shape how we're taking care of people. It's absolutely essential. And it's really the key. I mean, I think between that and addressing some of the social determinants of health, that could really shift the needle on patient outcomes. Truly, I think it's just an absolutely vital point to think about. And I think also finding like-minded peers. I know, you know, if you've had the experience of, you know, rowing in a single boat with people who are so closely aligned with you on something that's really hard, knowing they're going to have your back. There's nothing that feels better than that. I think it's why people stick to whatever, employment space they have. That's the reason why, because they have a group of people they know they can count on, who think, who believe, who are passionate about the same thing. So finding that kind of peer group, I think, is really essential too. Keeps your hope up, keeps you going. And it's so incredibly important. And then I think knowing local landscape, Lisa, you and Francis for sure, and well, all of you really, knowing what's this context I live in, who's out there, who's doing what, who are our allies, who can we partner with? All of that is essential to effective change. And then lastly, finally, this compassion, persistence. I just love that. That's gonna be my mantra, my motto from now on. So how about any of the rest of you? Do you have anything you want to add? I mean, there's so much that was said, but I just think, yeah, TJ.
I hate to be the first one always talking, but I do have something that you said that struck. When we are talking about understanding the landscape, I think that was one of our biggest surprises, is that we're in Beverly Hills. It's kind of an affluent area. And although we have, an affluent population, we definitely have our, the other side of that population as well. And it's the majority. And so our providers really didn't expect that we were going to see labor trafficking cases from our neighborhoods coming in through the door. And we do. We see them. We see them from students, that are going to local schools around us. So it's just surprising, I think, for all of us involved that, we didn't understand our landscape as well as we should have. We weren't providing the right care to the environment that we're in. And that's our job in a healthcare system, right? Is to know what services the community needs. So
absolutely. So critical. Anybody else want to add to what you're taking, Lisa?
I just sort of maybe continue what you're saying, TJ. It's not just about knowing the local landscape. It's also about informing people about the work that you're doing so that people know where you are, right? And so you can have these phenomenal programs out there, but we also have to create a system that allows others to learn about it. And, Beth, you mentioned about, determinants of health. How do we ensure that, the families who may be struggling the most, that may not have access to all the information, are being informed? And, I think for us, it's this outreach component as well, right? It's making sure that schools and universities and doctors' offices know what these services are, so that we can ensure that the people who really matter or who are marginalized in the system are able to have a voice and are able to know that, hey, we're not being forgotten here, and it may require us, I think, Francis, it might have been you who said, we have to challenge ourselves to think differently and be okay with the discomfort. And I think we do, in order to do this really well, like to reach some of these populations, I think we really have to challenge ourselves to not be the service provider that's just trying to do the best, but the service providers that are doing what's right and what makes sense for that community, not what makes sense for us at an organizational level.
Yeah. Well said, everyone. Yeah. Well, I hate to do this, but I have to draw this to a close. Right. So let us, here's the contact information for those of you who want to get in touch with any of these wonderful people. And I'm going to turn this over to Sherry.
Thank you, Beth, and thank you to each of our incredible honorees. We are so honored to be able to recognize each of your programs, and we appreciate your unwavering dedication to compassion in healthcare and for taking the time to share your work with us. Thank you to each of you who joined us this afternoon. We hope that this program left you as inspired as it has left us at the Schwartz Center. Please consider joining us tomorrow at 2 p.m. Eastern for the first of our 2 virtual information sessions on our new Healing Healthcare Initiative. We'll be sharing more about the program and the exclusive opportunity for 6 US-based Schwartz Center Healthcare member organizations to participate in the pilot at no additional cost. The link to learn more and register will be dropped in the chat, and we hope to see you there. Thank you all so much, and we look forward to seeing you again soon. Thank you.